New here? Subscribe. Already part of the team? Hit the like button. All right. We will go ahead and proceed with the seizure lecture. All right. Again, heads up, I do have it's a kind of mini lectures, and it does such a good job of describing what's happening with seizure pathophysiology that I feel like that's the quickest way to get us to where we need to be. I could just throw some words out there at you, but I'm visual myself, so but I can't draw. I think these are the most important points, that too much excitation is associated with glutamate, okay? And excitation is associated with positive ions, so the calcium and the sodium, all right? So if there's a positive or cation, then we're talking about too much excitation and glutamate, all right, with epilepsy. But epilepsy is two sides of the same coin, as they just mentioned, right? So it's also too little inhibition. So too much excitation along with too little inhibition, right? Inhibition meaning blocking or stopping GABA, all right? That's a negative ion, okay? I just want to make those connections as you continue to listen, because that's really what will be most important for you to know. What are you supposed to do when a person has a seizure as a nurse? Putting them on their side really helps, right? Because you don't want them to aspirate. We don't want them to aspirate, so we'll put them on their side. What else might we do to a person who's experiencing the clonic tonic type of seizure? Yeah, that becomes so important, right? Because they might inadvertently like knock things off. When it's the atonic seizure, they might fall forward, whereas if it's the tonic seizure, they might actually fall backwards as they immediately stiffen up and all of their muscles go stiff. Yeah, the absence seizure is also one that will easily be missed because the person they don't really sense that they went anywhere, right? They might come back and go, I feel weird, right? But for the person witnessing them, they might go, oh, you blanked out for a second, but you're back, right? So there can be an internal feeling and there can be an outward sign as well. All right, so that's my main overview, and we're going to go from there. That is an EEG reading, EEG. EEGs are how we can see this disruption in the normal brain wave pattern that you might see. And so they hook up the leads, right? It's kind of like an EKG, except the leads are placed on these little nodes on the brain, on the head, right? And this is where they're going to be able to pick up on the electrical activity of the brain. So this is what happens when a brain is on or having a seizure, excitation. All right, so abnormal behavior includes some of what we've already talked about, right? The spasmodic muscle contractions. All right, so it's a balance that is being imbalance between excitation and inhibition. All right, we'll talk about those two main neurotransmitters because I do believe you will need to know those, right? Which ones are causing the problems. All right, so I have, are we here? Okay, so too much gas, glutamate. All right, not enough break, GABA. Perhaps we can think of gas as the G in glutamate, although there's a G in GABA too. But there's a B in GABA that might help you remember break. All right. However, you need to kind of get those together in your mind. I like to also think of glutamate as being the positive ion. Remember the one that was 2 plus, calcium 2 plus, or sodium plus, right? Those are the cations, right? And the cations excite or give too much or add, all right? So if we think about the plus sign, we're adding too much glutamate, all right? Whereas with the GABA, we're inhibiting something or putting on a brake with the GABA, okay? I think that can be helpful. All right, I don't want you to get too like glazed over about this. This is really just another way to show you how these new neurotransmitters are working. Of course, this is a neuron, right? Neurons have synapses or gaps between them, right? And that's where these neurotransmitters are released, usually in the gap, right? And then there are receptors down on the postsynaptic neuron that receive and take that message on through into the postsynaptic neuron. All right, so without getting too much into brain chemistry and neurobiology, the two neurotransmitters that matter so much in seizures are the ones that we're going to be working on with our mechanisms of action, with our medications, will be GABA, okay, and glutamate. All right, and that's a little mitochondria right there, just to remind you that GABA is that glutamate and GABA are affiliated with the mitochondrion. Okay, makes sense too, because mitochondrion is where we store all the energy reserves. So if we're exciting, right, we're going to get a physical reaction, right? We're going to get those ATP molecules to actually cause a change in the muscles. All right, so we're not going to stick around there too long, but I just wanted you all to know the important neurotransmitters. All right, so because, and I'll tell you this again, whenever the consequences of, let's try this again. We saw this with the endocrine drugs, right? Whenever there's a tight therapeutic range, we have to monitor the drug, because when there's a narrow therapeutic index, right, where there's a narrow range where the drug is literally effective, you have to keep the drugs in the therapeutic levels or in the therapeutic ranges. So we monitor the adherence, because too little of the drug in the bloodstream, right? We're usually checking the bloodstream, blood levels, serum levels, right? If there's too little, then the drug will be subtherapeutic, won't do anything, right? The person will continue to have seizures. If we give too much, what usually happens with these neurotoxicity, right? Toxicity. So too much can be just as damaging as too little. So whenever we have these therapeutic drug, these tight ranges, we do TDM, or therapeutic drug monitoring. Usually involves drawing blood from the patient. It depends. We also saw that in antibiotics as well, right? Where there were certain medications, certain antibiotics that had a tight therapeutic range, because if that range got too high, the patient would experience toxic symptoms, right? You want to know what those drugs are, absolutely. But what we saw there is that the drug should be drawn from the patient at what point? The peak or the chow? Let's think about it. When do you want to draw blood levels to see if the drug levels are therapeutic for your patient? Do you want to draw them when the drug is peaking, or when there's a trough, which is generally the valley? You're thinking peak, peak, peak? Valley. Why? You want to catch it at its lowest concentration in the body to see if even at it's really, the trough is right before the next dose is due. All right, so that's what makes it a trough. It's right before the next dose is due, with the assumption that the levels are down now and we need to get levels back up, right? But if you draw during the trough, you get to know, well, at the lowest level, is it where it needs to be? Is it at a therapeutic level? Whereas if we draw it at the peak, it should be there. The drug should be peaking and doing its job. So if we go for the lowest point that it should be at, and it's still therapeutic, we know we're doing something effective. All right, any questions about that? Yeah. Well, what happens with toxicity, we assess for it. We look for signs. Yeah, because honestly, if the patient's not toxic and they're tolerating a little bit of a higher dose, we're okay with that. We're okay. That's what titration is. Titration is when the nurse is giving a med, drawing the blood levels to make sure it's at therapeutic levels. However, looking at the patient and seeing what those, and assessing, that's what assessment is. Looking at the patient and seeing whether we need to titrate down. All right. Or we might need to take vitals, right? We'll do this with your blood pressure drugs. There's one that you give by IV, right? And you give it by IV, but you titrate it to the patient's blood pressure. So if it goes too low, we just keep the dose up, right? Or actually, if the blood pressure goes too low, depending on what the target is, right? The goal, we look for those targets, and we try to keep the patient within the target. But it's really about monitoring not just the labs, but assessing the patient with your eyes, nose, all your senses. Okay, that's really going to help you. All right, so we do that, and that's important, and we're going to do that with different kinds of drugs, but anti-epilepsy drugs, you're going to see them called AEDs throughout the slides. Anti-epileptic drugs, this is so important. This is so important because they don't get the help if the drug levels are too low, and they go toxic if the drug levels are too high. All right, so you'll see that with all three of the drugs. I don't know why I keep trying because clearly we don't connect anymore. Okay. All right, so anti-seizure or AEDs or anti-epilepsy meds. All right, you'll see me driving these points home again because I really want you guys to at least have this basic understanding of what they're doing. All right, so mechanism one in these anti-epilepsy meds, we're going to talk about phenytoin and carbamazepine first. Okay, we're going to talk about these two first. They block the sodium channels. This is the most common mechanism for anti-seizure medications. Okay, so blocking the sodium channels are calming the storm. All right, so we're slowing down the excitatory, or this is the glutamate connection. Okay, so glutamate blocks the sodium channels and calm the storm. All right, by preventing the neurons from firing too rapidly. So it slows down excitation. That's what Dilantin and carbamazepine are doing. Phenytoin. All right, then there's that second mechanism that we talked about, enhancing GABA. That's pressing harder on the brake pedal, okay? Pressing harder on the brake. So remember, brake, B in GABA, right? Whereas the gas is the G in glutamate. All right, valproic acid and benzodiazepines take advantage of GABA. All right, valproic acid and benzodiazepine. So we're getting ready to break each of these four medications down, but generally speaking, they're either working by one of these two mechanisms. I want to make a point that valproic acid is considered broad spectrum because it does both. It blocks the sodium channels and enhances GABA, which is why it's considered, it's newer, but it is considered a first-line drug, broad spectrum. All right, until we figure out what's happening with that patient, we're probably going to put them on valproic acid. Okay, yeah, the one thing about seizure medications is that there are probably, only 2 or 3 that work. So patients are probably on one of those 3. As opposed to some of our other medications where they could be on any host of medications, they're probably on one of those 2 or 3, or 2. All right, so the number one rule here is adherence, okay? So for us as nurses, the number one rule is to monitor their therapeutic drug levels. But for patients, we are teaching adherence, okay? Never stop these drugs abruptly. They work a little bit like the psych meds now, those medications that treat depression, for example. You want to teach your patients, don't stop them abruptly because of the way they have to come up to blood levels in the system. Similarly, they don't want to come down with a crash. They want to be titrated down, okay? And every anti-seizure medication or anti-epilepsy drug is a depressant. All right, it's a depressant. So when I say that, what does it make you think as a nurse? If a patient's taking a depressant, what's something you're going to want to teach them? Yeah, no alcohol. Yeah, that's what I was thinking. Was anybody else thinking that? Good, good. No alcohol, because alcohol is a CNS depressant. So you could get into issues around operating heavy machinery, issues around, including vehicles, right? And being under the influence in a way that you might not have expected. All right. Contraception is also, because it's an enzyme-inducing drugs, drug, it will make oral contraceptives fail. All right, so got a couple of those this exam cycle, right? That will actually cause oral trauma. So when we see this, we teach our patients about having backup methods that are reliable. All right, we have a black box warning on these. I would love it if you guys all knew all the black box drugs that we have. All right, making sure that you understand which ones are box warnings and why. Okay, so and why do you think we have the black box warning on this one? Or on all anti-epilepsy drugs? What was that?
Like they affect pregnancy and fetal.
Yeah, it's this reason. Yeah, it's directly related to that. Any other thoughts? All right. All right. I think when we do get down to the anything reproductive or anything that can harm life and limb, we go to the black box warning. All right, so we've got a couple of, we talked about this in the 8-minute video, the idea of a focal seizure versus a generalized seizure. And I showed you the EEG readout for a person experiencing a seizure. So you'll see again, unlike the EKG, where there is somewhat of a pattern, a brain wave is just kind of usually moving along on some kind of theta waves or delta waves, right? But you can see that the excitation comes and creates just almost like a electrocution, right? Where things just kind of come to a hard stop. So when it's a focal seizure, it looks like this on the EEG, right? Things produce like a mixed wave. Whereas when they're generalized, you just get a complete shutdown of most functions, right? Considering that the brain is responsible, the CPU, for like all kinds of bodily functions, a generalized seizure is going to create generalized loss of function. All right, so starting in one part of the brain, right, the focal seizures, involving the entire brain all at once, the generalized seizures. We saw the tonic-clonic, which typically is called the grand mal seizure. It's the classic type where you're going to get the stiffening of the body or the tonic part, and then the jerking phase, which is the clonic part, all right? Not necessarily atonic. Atonic means loss of tone. So that would be where you completely lose tone. All right, and then you have the absent seizure, also known as the petit mal, right? It sometimes comes around the same time as the grand mal, but they don't necessarily travel in pairs. You see them most in children where they might have a staring spell, right? They're not necessarily having the muscle involvement, but this is kind of an early indication or an indication early in life that a child might have a seizure disorder. So it's a bit off-putting to be around someone who is experiencing a seizure. But you'll learn after a while that if you're working with a patient and they begin to experience the seizure, hopefully you'll start timing it to make sure it's not like a 5-minute seizure, because that's status epilepticus, status epilepticus, and I'll show you what that is in a moment. It is an emergency, not a small deal, right? But otherwise, safety, what we've mentioned before, keeping things out of their way, making sure there's nothing blocking their mouth. Hope I keep wanting to use that. All right, so we mentioned that safety, airway, timing. I got this picture from Adobe stock. And I thought, I'm going to use it anyway, even though it's kind of odd that they're putting their hands on her mouth to, like, I would imagine these are parents and their daughters. They were in a park and their daughter has fallen from a seizure. They're kind of opening her mouth or doing something around the area of her mouth. And I think it's primarily because they're concerned about her airway, right? But honestly, you don't need to touch the patient per se. You just need to allow them to, just to see and make sure that there's nothing in their mouth. But then lying on them side will help. Lying them on their side will help them eject or release what's in their mouth. You also often will see drooling or foaming at the mouth as the person is experiencing those the tense muscles in the mouth as well. This person that I know bites his tongue pretty much every other time he has a seizure, so he has to during the convalescence or the post-ictal phase, he's always talking funny because he's bitten his tongue during the seizure. Rescue meds, we'll talk about those in a second. But seizure precautions in general definitely just kind of involve allowing that patient to have space. All right, so now we're going to talk about phenytoin. It's given as a PO drug, but the IV version of it is called phosphenytoin. Okay. Phenytoin is just super common. It blocks the sodium channels. Remember, the phenytoin is going to work by the first mechanism that we mentioned, where they're blocking the cations or the positive channels. Okay, so that's going to be your sodium and your calcium. Okay, it's great maintenance after a status epilepticus seizure. Status epilepticus, right? It's good maintenance after that, especially with benzodiazepines. But otherwise, they're used for tonic-clonic seizures and focal seizures, all right? And we might do a thing called IV loading. What do you think IV loading is? I want to give you a chance to maybe guess what it is if you've never heard of it. So there's a med that we're going to send a patient home with that's PO. Well, we might use phosphenytoin in an IV loading scenario. All right, well, patient has just come in, they've had their first seizure. All right, maybe they've had some seizures that they haven't come in about, but this is the first one that they've come in to get treatment about, right? It was a bad one. Maybe it was status epilepticus, or maybe it was one that just completely surprised the heck out of them and they now need treatment, right? So this will be the first time. We might load them with an IV version of the medication that we're going to send them home on. All right, we want them to immediately get some therapeutic relief from this seizure. We probably don't want them to necessarily be admitted because we do have therapies for them, but we'll go ahead and start them on this medication IV. Okay, right there in the emergency room, we'll start them. All right, we'll send them home on medications and to their physician so they can get an official diagnosis and all that other good stuff. But if they came in suffering from a recent seizure and they don't have any medication at home, it's not already in their system and they just skipped a dose and that's why they had a breakthrough seizure, then we're probably going to use the IV load to get them back. Maybe they were on it and their insurance changed and now they don't have access to the medication. That's super unfortunate, but I bet there's somebody out there experiencing that right now with all the changes that are going on. And maybe they've been without their medication for a while and they start experiencing the seizures and they're just managing the seizures. All right, they might get an IV loading when they, after a tough one, like one that causes more like, what do I want to call, like a worse outcome than another. Like sometimes a person can have, more to recover from because maybe they hit their head when they fell. That said, the recovery time after a person's experienced a seizure who hasn't been on their medication might be longer, and therefore they might go to do the IV loading to get things back up to therapeutic levels as soon as possible. And here's the range, guys. I want you to know it. I want you to know this one forever, not just for the test. Know this one forever. Well, until you take the NCLEX. I would say forever, because what if you're an OB nurse and you don't need to know that, right? Because it has nothing to do with your patients. I would definitely know this though until you take the NCLEX, and then you can chuck it out of your brain, because they bring this one up a lot because of the tight therapeutic range. I think it's a relatively easy range to remember, and only remember the numbers. Don't worry about micrograms per milliliter. The NCLEX will provide that to you. So will the ATI exams, okay? So worry about the number. Do what you got to do to keep that one in mind, okay? Therapeutic range is super important for that. All right, so what are we doing in terms of nursing priorities and safety? They're going to be the same every time, but I want to point out this word here, nystagmus. What is that? We like cool words here. Yeah. Yes, it's when the eyes don't track. I personally love, and this is terrible, I don't know why I would admit to this, but I do love to watch body cam videos. Anybody else? You, me too. Yeah, absolutely. And it's just what I watch to go to bed at night. And and I love to see them give a field sobriety test. It's just like my favorite thing to do. Some people can really handle their liquor. I mean, they are pretty good. They want you to stand with your feet up like this for a long time. They want you to walk along the line. But the very first test they always give in those field sobriety tests are the tests to see if you can follow the tip of the pen with your eyes only, not your head, and to see if you can track. I think it's so funny. It's like the funniest thing to me that they don't get it and they always move their head. And I'm like, that's how they know you're drunk. It's not the nystagmus test, which is really what they're testing, right? It's the fact that you cannot follow instructions in this moment. I was like, I tell my husband all the time, I would never drive drunk or impaired. Absolutely not. But like if I ever get one of those tests, like I'm gonna have you have to tell your brain, do not move with your head, just your eyes. Anyway, I don't know. It's just I feel like they should be able to do that, but apparently not. When you're impaired, you cannot follow directions, but you also it's very difficult to not move your head along with that. And they need you to do that. Why? Because when your head is still and you're tracking only, I still did it, and you're tracking only with your eyes, they can see the tracking. They can see the nystagmus. All right, which is really just like the stuttered staccato movement of the eye as it goes from left to right. So it will kind of do that jerky movement. It won't be smooth. Okay, so that's nystagmus. And I hope my story helps you remember that nystagmus is an adverse reaction of Dilantin or Phenytoin. Okay, really interesting, but it's one way that we as nurses can assess easily our patients to see if they are toxic. Okay. They might have slurred speech. What is ataxia? Mm-hmm. Yeah, it would ataxia. So it can be involuntary muscle movement. It can be the lack of coordination. So you just did this right here to imply a person who is ataxic will not be able to do this very easily. Okay, they will have problems with that. Sometimes they have problems with lifting the arms, right, and doing this. Coordinated movements are difficult for a person experiencing ataxia, meaning the loss of coordination. Okay. Um, so gingival hyperplasia. I have a picture of that coming, but what is that? Gingival. So gums, gingival, yes. Hyperplasia. Hyper, too much. Yes. Overgrowth. Yes. Overgrowth of the gums. So too much growth in the gums. So there will be this overgrowth of the gums and kind of gives you an indication that your patient's probably been on phenytoin for a long time, a good little while. It takes a while to get to that. All right. Now, then there's this rash, this incredibly scary rash that is called Stevens-Jorgensen syndrome, TEN. They add that piece on there lately. But it's a horrible rash, not like any rash you've seen. I do have an image of SGS in the picture. So what happens is if that person starts experiencing any of these feelings, right, it's a note to you as the nurse to examine them for toxicity. And examine usually involves like an assessment, but also get into those labs or have your team understand that we don't have a recent level, right? But honestly, if your patient comes in and you see in your question that your patient has come in post-ictal, all right, following a seizure, your first thing I want you to think about is what are their levels, all right? How, and if there's nothing mentioned about where their therapeutic levels are, and you have the option of choices that allow you to inform the team or do something that lets it be known that you're going to want some drug levels soon, show that, right? Show that you know this is important, okay? Now, we can give phosphatoin IV, right? We mentioned that, but we can give phenytoin IV as well. This is a pharmacy thing. This isn't really a nursing thing, but when you do get phenytoin or Dilantin IV, you have to give it slow and monitor the heart, findings there. Just know that phenytoin has a ton of safety indicators, all right? And IV safety generally involves titrating at a slow rate, all right, giving as ordered at a slow rate, but monitoring for hypotension, particularly. We're not looking for hypertension, hypotension, and arrhythmias. Arrhythmias could be, anywhere from tachycardia, to the more serious ones. All right, potassium shouldn't be too affected there, so I wouldn't necessarily look for potassium issues. All right, so yeah, this is also the enzyme inducer. And whenever you see enzyme inducer, I want you to think what? Enzyme contraceptions, okay? Contraception teaching, right? Education, because those enzyme inducers cause those contraceptives not to work as well, okay? I'm going to mention here, okay, say a person's had a seizure and they're on a tube feed. Maybe that happened because they were in a motor vehicle accident after having a seizure. Maybe something like that is happening. Or maybe you just happen to have a person who is an epileptic who also happens to be on a tube feed. All right. Know that phenytoin causes tube feeds to bind, right, or coagulate or clog up the G tube. All right, so we don't want that. So we hold this medication before and after it's given for PO doses, right? Tube feeds wouldn't have any connection unless it was tube TPN, bless you, with they wouldn't have any connection with actual your cardiovascular system, right? The GI and the cardiovascular system are two different systems. However, if the patient's on PO doses, the GI system could be involved, right? So tube feeds bind them. I'm sorry, tube feeds hold them so we don't have a bind. All right. 10 to 20, that's our number, all right? 10 to 20 is our therapeutic drug range for phenytoin, all right? And remember, toxicity goes from first the jagged eye movement or nystagmus, then to coordination problems, right? Or the inability to coordinate, all the way to confusion. Now, confusion is a late sign and usually a bad sign of any type of adverse reaction. People look at confusion like, oh, it's probably just, they're confused because they're in the hospital or something like that. No, confusion usually means that there's brain involvement in whatever medication interaction we have. All right, so don't look at confusion like it should be before some of this other stuff, right? You might get the eye tracking issue first, right? Followed by the coordination issue, followed by confusion, and then coma. All right, so we have to be so careful with our nurse monitoring here. All right, here's just some of the labs that we might also look at because phenytoin may interact with our albumin levels. All right, so this might actually impact our target therapeutic ranges. All right, so our labs will want to check albumin. We want to check CMP. What is CMP? As one of the tubes that we can collect, right? There's the pink tops that do CBC, and then there's the purple tops that do CBCs, and then there's the pink tops that do these CMPs. Metabolic is in there.
Yeah.
Panel, yeah. This is your metabolic panel, all right?
What's the C?
Comprehensive. Thank you.
Comprehensive.
You're comprehensive. All right. It's going to have your electrolytes in it. It's very comprehensive. It's going to have mostly your electrolytes in there, but if you draw a comprehensive metabolic panel along with a CBC, you're pretty much going to cover everything. And then liver tests as well, your liver enzymes, you're pretty much covering everything. But CMP is going to definitely cover all your electrolytes and your albumin. Albumin is another test. All right, so CMP, always think electrolytes. Your albumin levels, definitely. And we don't really need to check CBC here, so let's not even mention the complete blood count. All right, we don't really have any interactions with your blood count. This is what hyperplasia, gingival hyperplasia looks like. Just overgrowth of the gums, okay? And we associate that with phenytoin. So here's the summary slide, has all of the important information on it, right? I feel like everything on this slide is important to know. All right, sodium ions, delaying or inhibiting sodium is what these medications are doing, right, to stop the excessive firing. Phenytoin. Now, how do we reduce gingival hyperplasia? We teach the patient to go and see their dentist more regularly, because the dentist is who will help them truly control this issue. But there is the matter of brushing and flossing the teeth very carefully, multiple times a day. All right, on that. And we do want to educate our patients about the Stevens-Johnson's syndrome rash. All right, if they have any kind of rash, even if it's just dermatitis from latex or something that we don't know about yet, but there's a rash, all right, have them call. All right, have them call. Also, drowsiness or unsteady gait, because that's given us indication about ataxia, and drowsiness is giving us an indication that they might be too sedated as a result of too much medication. All right, or maybe they just need education around what to do when they feel sedated. All right, so the check for understanding tests. All right, so here's the question. A patient on phenytoin becomes unsteady with nystagmus. Level returns 28 micrograms per milliliter. What is your priority? And remember what we said about priority questions, all right? So what is it? A, give next dose on time. B, hold dose, implement fall precautions, notify the provider. C, encourage fluids and recheck in a week. Or D, switch to chewables. I never fixed the slides from before when I said that I'm going to come back to the slide, so I got a feeling. All right, what do we like? The B option? Okay, we're absolutely going to like the B option, and not just because it's always the B option. Okay. All right, so that is correct. Okay, we're going to hold that dose. Why? Because why we're going to hold it?
The toxic one.
So we're thinking it's toxic, right? Where that level tells us that we might be going above the therapeutic range. Why the fall precautions? Because what's that? Oh, that's a reason in and of itself, right? Just we could put them on there because we know they have seizures. All right. But why do you think this question is mentioning it as if it's something new that we need to do? Yes. Yeah, that little part about the unsteady. What's the technical term for unsteady? Ataxic. All right. So we think someone is ataxic and they have nystagmus, we're thinking toxicity. And we know that level. All right, we're definitely going to implement fall precautions, notify the provider. Why do we notify the provider? Why don't we just hold it? Why do we notify the provider? What are they going to do?
Adjust it.
Absolutely. You never notify the provider without knowing exactly what that provider is going to do. It's not like you're going, not my problem. You're literally doing it because you know that there's something in their scope of practice that needs to happen right now. Okay. And you know what it is. Excellent. All right. So now, question 2. The client taking phenytoin has a serum level of 25 mics per mil. Which clinical finding would the nurse expect? All right. Do you think this patient is going to have A, hypertension, B, gingival hyperplasia, C, nystagmus and ataxia, or D, a seizure? Okay. You guys like C? I'm hearing C. Okay. There was a non-B answer. I can't believe it. I didn't go back and change that either. So, all right. So we're getting it that these are two of the, NCLEX and those ATI questions, they love to like bring in or filter in an anatomical word or some kind of word that's considered medical jargon, just to kind of keep you honest, right? Because that's what we're here to do, to be able to learn how to talk to the team using these $5 words. That said, knowing these and what they mean will serve you well throughout these tests. Again, gingival hyperplasia is a late long-term use sign, usually. It doesn't necessarily, it's not an immediate sign of toxicity. All right, so we're moving on to carbamazepine, all right, as a prototype drug, because Dilantin, you saw with phenytoin all of those side effects, right? It's not the easiest drug to use, all right? You can't quit it suddenly. There's just so many reasons why it's tough. All right, this one here, also a sodium channel modulator. It's good for focal and generalized tonic-clonic seizures. And here's our target range for carbamazepine, 4 to 12. All right, 4 to 12. What was the other one for phenytoin? Just to do a quick check. 10 to 20. All right. So this is called, what I just did there is called spaced repetition, where you ask someone a question, but you all ask yourselves again a day from now, okay? Or perhaps even 5 or 6 hours from now. I promise you the repeated repetition will help you learn. I'm hoping that's what's happening in the class, and this is why you guys are doing so well right now, because I'm repeating things that are important and that you're locking them in and getting them down. I'm hoping that that's part of the picture, but do that to yourself as well. Repeat something, especially when they're numbers that need memorizing, right? Just like early and often remind yourself or do things to remind yourself of what they are. All right, autoinduction lowers levels initially. Autoinduction. So let's see if I have a better definition. All right, so when carbamazepine is first given, right, it actually literally causes the levels represented in the bloodstream to look a bit lower than they are initially, right? It has its own means for working through the mechanism of action to kind of get up to therapeutic blood levels. All right, so it's important. That's a term. I don't think that term is as important as what happens here, knowing that the levels will be a little bit lower initially. And as it gets up to therapeutic blood levels over time, it'll be closer to our target 12 micrograms per milliliter, right? But if a person's only been on carbamazepine for, say, a week or two, they may still be low in the therapeutic ranges, but not necessarily at risk for a seizure because they're so low because of autoinduction and it being the earliest phases of their seizure treatment. Okay, so I could see a question that might say, oh, a person's been on carbamazepine for a week and they are at a therapeutic level of 5. What are you concerned, or what would you do? And maybe one of the options is, or, get the provider to give you a bigger dose, right? But no, you're going to remember the levels might be a little bit lower initially, but they'll get up. All right. So they do extended release versions that could help you remember that because carbamazepine comes in these extended release dosages, that it actually might take a little bit longer than normal to get up to those higher drug levels. All right. It gives smoother peaks. And you want that for your medications. You don't want these really high peaky peaks and really low valleys. The patient won't get the type of, comfort that you would want, in a medication that you have to take so intensely. So we like carbamazepine, but here is what the skin reaction looks like. And this is why we get the black box warning for carbamazepine. So as you learn about the black box warnings, associating them with certain drugs, be sure to know why that black box warning exists for that med, all right? For phenytoin, it was the black box warning was due to the contraceptive risk, right? But here it's because an individual can get, there are multiple warnings. One is the skin reaction that you see here, the Steven-Johnson syndrome, Jorgen syndrome, all right, here. But there's also this aplastic anemia, all right? So we didn't need a CBC before with phenytoin. We could be okay with the comprehensive metabolic panel, but for carbamazepine, you need a CBC to keep up with this patient's red blood cells, white blood cells, and platelets, okay? Because the body will stop making them completely. So with this one, aplastic, I want you to see that the A here means none, all right? It doesn't mean lowered amount, or that you might see with penias, right? With the cytopenias and the thrombocytopenias, and the penias are little or lessened amount. Aplastic implies that the body stops making them. That is not compatible with life, is a black box warning here. It's very rare, but if it begins to happen, we have to act quickly, okay? So we look out for those kinds of things. How do you think you might be able to assess your patient for this finding? What would a patient who is getting ready to experience aplastic anemia going to possibly show up like? Like what's something that might make you go, oh my gosh, I need to check and see if this person's possibly going through a dizzy? Not quite. I want you to save dizzy for those that are more like cognitive. This one's going to be a little bit more of a lesser, like it's a worrisome sign, but it's kind of common. Well, not common, but you see it. If a person suddenly stops making white blood cells, what are they gonna, what might happen? Yeah, right. So they might get an infection like that. All right. So we look for things like coughing. That's kind of, that's not very specific, right? But in combination with, okay, maybe their platelets are all, the body suddenly stops making all of them. So the platelets go away. What are you going to see? Bruising, possibly bleeding over the littlest stuff. All right. So they might just be, might have slammed their hand on the bedside stand and they have this huge bruise there. All right. And you go, oh, I'm worried about that because they're on carbamazepine. All right. So bruising for the platelets, for the white blood cells, an opportunistic infection of some kind. So maybe coughing when it's not really a lot of colds going around, something like that. And RBCs, if those are suddenly low, what might you see? RBCs, red blood cells, when a person's red blood cells suddenly go low, how might that present itself clinically? Cyanosis, so implying that, okay, so maybe they're like blue, okay, maybe blue lips, blue fingers, that would be extreme. That would be like a bad late sign. Somebody really missed some other stuff before that, but that's possible. It might affect their breathing. It might affect their activity levels, right? Because we don't have enough red blood cells on board. We're anemic and we behave like anemic people do. All right, so we don't want any of that to happen. I spend time on that because black box warnings are usually not sustainable with life. Like if something happens, in the case of the contraceptive one, it could be harmful to the unborn child. In this case, it could be harmful to the individual. All right, so lots of black box warnings. There's also this third one, a risk with the HLA-B genetic marker. It's seen in certain Asian populations that if they have this genetic marker, this medication will harm them. Okay. So do we screen everybody for the genetic marker? No. It's expensive to screen people for genetic markers. But if the person has a family member or if they know they have that, they're going to want to tell people, about that, right? And if they do start to experience these kind of life or death symptoms, they probably will do a screening on that person just to make sure. All right, so it also may reduce oral contraception. All of the AEDs do. All right, carbamazepine. I've got a little purple top here to show you that we're going to need the CBC for the carbamazepine, okay, because of the terrible black box side effect of agranulocytosis. Agranulocytosis usually is referring to the granulocytes, which are white blood cells. But that aplastic anemia part is losing the RBCs and the platelets. Okay. I think of aplastic like the beginning of a platelet, and that helps me to think about no platelets, aplastic. I don't know. It's kind of silly, but all right, and 4 to 12 is your target range. And notice that it varies with institutional policy. And or you need to verify this because of that autoinduction that we talked about before. Sometimes the therapeutic range is considered to be maybe possibly lower, but there's always a little explanation there to help the nurse remember that, hey, it could be that they're early in their therapy, so it's okay for it to stay a little bit on the smaller side for a little bit of time. All right, so this may actually result in an increase in the dose after the loading doses have happened. All right. We don't just want to look at the CBC. We also, I should have put here a little pink top for the cardio. I'm sorry, not, I want to say cardio, but for the comprehensive metabolic panel. Okay, so we'll take both of those. All right, maybe even do a genetic test if we think it's relevant. All right, so that's carbamazepine. And those are the details for your card, okay? Really pointing out. Now, signs of infection might include fever, sore throat, or mouth sores. Those are kind of like the ways to think about what happens when your white blood cells are suddenly gone, okay? We watch for signs of infection. All right. So here's our question. A patient on carbamazepine taking combined oral contraceptives asks about pregnancy prevention, best response. We love the word best because that just lets us know that 2 of these are going to be correct. All right, at least 2 will be correct. Your job is to find the best out of multiple correct responses. So let's see the first quote. Carbamazepine doesn't affect birth control pills, end quote. B, quote, use backup contraception because carbamazepine can lower pill effectiveness, end quote. C, quote, stop carbamazepine before intercourse, end quote. Or D, quote, skip the pill on seizure days, end quote. You're liking B, everybody? All right. That is correct. All right. Makes sense. I think you guys still would have been able to pick that out of the crowd because actually there weren't 2 correct ones here. All right. They're actually all, well, this one's not wrong. It's just, I mean, it's not, it's, well, they're not, this is not one of those scenarios where you have multiple correct answers. There's an obvious choice here. Okay. Backup contraception. All right, question 2. Which lab abnormality is the most concerning in a client taking carbamazepine? All right. So it doesn't hurt for you to know your sodium levels, guys, your platelets, your white blood cell counts, your potassium. It's only going to help you as you move further along. All right. So we look at that sodium level. Is it abnormal? All right. So not concerning. What about that platelets? Not worried about that. That looks okay to you guys. What about this white blood cell count? We don't like it, right? What about that potassium? It's okay. All right. So which option is most concerning in the client taking carbamazepine? Yeah, we don't like that the white blood cells are that high. Okay. And platelets, though, we love them that high. We don't like when they get too low. All right, so looks like we are ready to move on to valproic acid. All right, it is a broad spectrum, meaning it will hit at multiple mechanisms of action and therefore are great for patients who come in who we're getting started with therapy on, right? Because we'll see what works. All right. So generalized, including absence seizures, myoclonic, focal, and it's taken as migraine prophylaxis. A lot of times we don't know exactly how these drugs work. We just somehow found out that they also work for other things. It's called off-label use, and then we'll create a new off-label use for it. So good to know it can help the migraine people because they don't have a lot of meds that they can take, the migraine folks. All right, here's another range to remember. 50 to 100, valproic acid, okay? We have to know those ranges because there's such tight therapeutic ranges. All right, so I forgot what my BBW stood for. Oh, black box warnings. All right, for valproate or valproic acid. All right. The black box warnings for this one involve hepatotoxicity, pancreatitis, and teratogenicity. All right, what's hepatotoxicity? Liver toxicity. Okay, great. What's pancreatitis? Yeah, so that's an acute um inflammation of the pancreas. Not good. We don't like that. All right, and what about teratogenicity? Oh, I'm sorry, teratogenicity. Right. So we have fetal maldevelopment. There's literally something like spina bifida, something that is not growing as it should. Okay, teratogenicity. All right. Other black box or other warnings that may not be black box warnings might include thrombocytopenia. And what is that? A small amount of thrombocytes. And thrombocytes are those clotting factors and those white blood cells that help us respond to an injury when there's been a cut in the skin. All right. So we could have too few thrombocytes, weight gain, tremor, hair loss. All right. Which feels a little bit like some of the stuff you experience in uh, thyroid issues, right? I don't want to confuse you guys, but I could see some of those similarities there. All right. And hyperammonemia. What is that? Hyper is too much, right? Ammo or ammon would be ammonia. And emia is in the bloodstream. All right. So too much ammonia in the bloodstream, not good. It's most certainly is what would cause the hepatotoxicity. Ammonia is a byproduct of things that happen in the liver. Ammonia is a buildup of waste products, and the liver is not going to like that. Okay, so hyperammonemia is the culprit of the hepatotoxicity. All right, and that is why we got to monitor those liver function tests. All right, because we got to see what the ammonia levels are, and we got to see how the other parts of the liver are doing. All right, so here's one where we get LFTs. We want the platelets because of the thrombocytopenia. Okay. So knowing all your labs will be very key for your therapeutic drug monitoring medications, right? Which include all of your anti-epileptic meds. All right. Ammonia, when it builds up too much in the bloodstream, will cause mental status changes. They most absolutely will cause a person to be confused or irritable or even aggressive. All right. So mental status changes in a patient that's been just a perfect little patient for you, all right, may indicate that we've got some ammonia levels. Let me check. All right. Who else has super high ammonia levels and will behave differently because of it? Just a random aside. Anybody? Who are you thinking? Anybody thinking? I'm thinking about alcoholics. Alcoholics will have very high ammonia levels, and we always want LFTs on our alcoholics. We always want to see what their livers are talking about. And ammonia. So this is to help you remember that ammonia is an LFT issue. Too much ammonia is a liver thing, and that hepatotoxicity travels along with those concepts. Okay, so valproate, hepatotoxic, and hyperammonia and LFTs will be the way we keep all of that in check. All right, we're checking for those. All right, same thing with the thrombocytopenia. Definitely want to check those platelets to keep an eye on that. All right, so here's our summary card. Black box warnings are for hepatotoxicity and pancreatitis. All right, whenever you have a patient who's experiencing thrombocytopenia, we're going to look for bruising and bleeding. Okay. Platelets too. Platelets are the thrombocytes, okay, of choice, the ones that we're really looking at. All right, so platelets too low, we can get bruising and bleeding. We got to figure out what's happening. All right, because we can always give more platelets to our patients on valproic acid. We can just give them platelets. All right, we got the therapeutic range down and our nursing interactions. Let me see if I missed anything here. Again, because we're working with these enzyme inducers, we have to counsel or teach our patients who are childbearing age on the risks, okay, and the need for that backup effective contraception. And the reason isn't because of the reason for this education isn't because it's an enzyme inducer. It's because if you do get pregnant, your child has a large probability of having birth defects. All right. So if a person wants to be pregnant, this is important information, right? Because they might say, well, I'm not going to use a backup because I want to get pregnant. And then you say, well, actually, you really should not get pregnant because the risk to your unborn baby will be great. All right. And for those who do not want to get pregnant, you absolutely need to use a backup. All right. So here are our main points. For severe stomach pain. Oh, why do we check? I had to check myself. Why are we looking for severe stomach pain? I want to be able to explain that for the perfect. Wonderful. All right. So pancreatitis will start like severe stomach pain. All right. So we advise them if you start having severe stomach pain, call immediately. All right. Why the yellow skin or eyes? Mm-hmm. Yeah, because we're thinking about the liver involvement and the unusual bleeding or bruising. Well understood, right? Okay, good stuff. All right. Okay, so which symptom reported by a patient taking valproic acid requires the most urgent evaluation? All right, most urgent. Is it A, mild hand tremor? B, gradual weight gain of 5 pounds? C, severe epigastric abdominal pain? Or D, occasional nausea?
C.
Yeah, we like C, right? And mostly because they're giving us these adjectives that are helping you out here. But the NCLEX would be hand tremor, weight gain, epigastric abdominal pain, nausea, right? It wouldn't give you those helper words there. So good choice. And knowing the why is the most important. All right, so I want to talk about two new generation anti-epileptic drugs that weren't discussed in the others because they kind of have they work the same, they work similarly, but they're newer and less problematic. All right. They both, well, one carries the black box warning, the SJS, or the Stephen Jorgensen's syndrome rash. All right. Now, generally speaking, with this one, Lamictal, it's because of the main key risk, then we're titrating the drug. All right. It works well. Otherwise, we just titrate the drug to prevent the rash. All right. And by doing that, we just continue to give the drug until the rash appears. So titration means watch the patient for symptoms. All right. And you just escalate the dosage until you experience the symptoms. All right. And then you pull back. Okay. So we give as much as they can tolerate before they start getting symptoms. And with Lamictal, we do that. That's a main focus. Now, Keppra, okay, and it causes agitation, anxiety, depression, and this thing called Keppra rage. All right, and I tell you that story because I don't want you to forget that Keppra, mood changes. Right, you want to look out for mood changes with that one because they'll literally rage on you. The sweetest, nicest people. All right, so that's the one we just mentioned. Ask the family to report mood changes early. All right, the family knows the patient, so they will know if something seems off and they're just not themselves. All right, so that's important. And I'm just reiterating here, you go slow with the Lamictal, all right, to avoid that SJS rash. All right, so we titrate over time. Okay. Now, if that person happens to be on Valproic as well, because yes, these drugs can be used in combination with one another. If you're using Lamictal and Valproic, Valproic might actually raise the level of Lamictal. And so the person or the nurse who's titrating this will need to titrate even slower. All right. You will never be thrown out there to the wolves to titrate a medication with a client without pharmacy's full involvement. Okay. Pharmacy will be like very specific as to how and under what parameters you will titrate. Okay. So don't never worry about that. But it will be important to consider all those things as you move through. Okay, time. Now we're on the benzodiazepines. All right, if an emergency happens to an individual experiencing seizures, what's the biggest emergency that can happen? Status epilepticus. All right, that is the biggest thing. And how do we define it? A seizure lasting more than 5 minutes. All right, so if a seizure that's why you want to time a seizure as soon as it starts, because you want to be able to know if that seizure has gone beyond its typical, 1 minute, 2 minutes. When a person's having a seizure, it seems like way longer than 2 minutes. It really does, because you're worried about them, you're doing things, and you're waiting. But 5 minutes will feel like an eternity while you're watching someone actually seize. So with that said, we get to 5 minutes, they should take a benzodiazepine. Okay, probably will be IV, right? Because if they're, if they just recently had this episode of 5 minutes or longer. So we're going to get a benzodiazepine in there. We're going to check their blood sugar. All right. Because it's probably super low, because all of that, it's kind of like coming back to fight or flight. Whenever a person is using their muscles in this way, there is a ton of glucose being used. All right, a ton of glucose. Glucose is also the main fuel for the brain as well. So if the brain is experiencing excitatory impulses and firing off at this rate and using that much glutamate, you better believe that blood sugar is going to be super low. If that person hadn't eaten for the day, even lower, dangerously low. Okay, so we want to correct low blood sugar in a person who's just had status epilepticus, because they most certainly used a ton of glucose in that episode. All right. Now we put them on the benzo to stop the status epilepticus. Why benzo? Does anybody know why we are going to switch over to a whole new drug class if a person experiences this particular? Yeah. Yeah. So benzos stop, and they stop because of which neurotransmitter? GABA. Yes, it's the GABA with the break. All right. So the benzo stopping it, stopping breaks, benzos, breaks GABA. Okay. The GABA stops. So you got one, the glutamate like slows, calms the storm, slows the excitation, right? But the GABA is what really applies the brakes, okay? And GABA is what's in benzos. All right, and then the phenytoin comes in and kind of it's hopefully getting up to blood levels fast enough to prevent the next seizure from happening. All right, and that prevention is happening as a result of glutamate being inhibited. All right, so I'm back to that slide about phenobarbital, which is our main benzo. All right, so it's in emergencies. Of course, we're going to watch for sleepiness and slow breathing because it's a CNS depressant, probably the granddaddy of all CNS depressants. So the patient who probably was already on an anti-epilepsy medication, might experience even more sleepiness. Okay, so we're definitely going to look out for that. And definitely check their breathing and alertness as a nursing intervention, or teach the family to do so. All right, so I'm just reviewing this again. First aid for the seizure. Ease them to the floor, protect their head, time the seizure, turn on to side. Okay, never restrain them, right? Because they literally do need to fire off those electrical impulses. They do, like, they will be hurt if you restrain them. They will actually have more recovery because they couldn't like fully release the tonic-clonic um, uh, muscle involvement that's there. So don't restrain them. Don't ever put anything into their mouth. They're unconscious. They don't have a way to, like some people might think, I need to go ahead and get that benzo in there. Okay, I need to give them their medication. But until that seizure is completely over and they're conscious, definitely don't want to put anything in the mouth that could be asphyxiating or aspirated. All right, and then we're going to call EMS at 5 minutes. Um, if they've been, I mean, it's a bit late, to call EMS, because not every person experiencing a seizure is going to call EMS. We learned that as a family after a while. You just can't call EMS every time your loved one has a seizure, even when they're uncontrolled. They do need to go to see their physician, but you're not going to call every time. But if you hit 5 minutes, it's a need for a call because they need to come here with their benzos so we can help this patient right away. All right, so here are our ranges mentioned for each of our drugs talked about today. All right, the ranges, the therapeutic ranges are mentioned. The particular labs that need to be monitored for phenytoin, its albumin, and the CMP. All right, CBC, and particularly sodium, all right, for carbamazepine, and the LFTs and platelets for valproate. And then that assessment, right? Assess the patient for neurological changes with phenytoin. For carbamazepine, we want to assess them for dizziness or diplopia. Anybody know what that? You seen that one before? Double vision, dye being 2, diplopia, okay? You'll see that sometimes on carbamazepine if I didn't mention that before. All right, and then valproate. Confusion is a late sign and usually indicates that ammonia levels are too high, but that's why we keep up with the LFTs, okay? More of the same here. Just giving the likely drug in the middle column, immediate nurse actions on the right-hand side, and those symptoms with the terms that we like to use over here on the left. Making those connections, guys, will be the key. This is out of order, but this should have been over there where I was talking about the benzodiazepine, but other rescue medications that might be used with a person taking anti-epileptic meds might include Lamictal and Phenytoin or Valproate, rescue meds. So it's presumptively people are not on these medications. They're just using them when they get into a scenario where they need to be rescued. And rescued means that they're experiencing status epilepticus. All right, so they might be put on benzos first, and then next, these hardcore rescue medications, usually IV. So phosphenytoin IV or valproate. Okay. And when we are giving the rescue meds, we are watching out for oxygen levels, SpO2 levels, so perfusion levels, all right, in the periphery as well. Cardiac implying an EKG, all right. We also want to look at the EKG. And then we're monitoring. There's just so much monitoring of the labs and the patient themselves to see what the patient's doing. Glucose levels, especially after status epilepticus, because they are going to be low, super low, okay? And then document everything. This was a heavy talk, this lecture, because there's so much nursing intervention, but knowing the pathophysiology and the pharmacology will definitely kind of lead into what your proper nursing actions should be. There are safety things. I don't think there's anything new here. Enzyme induction usually means that they are going to decrease oral contraceptive use. All right. Any of the enzyme inhibition drugs, all right, will increase the level of other drugs. And we know valproic acid, along with Lamictal, that one that we mentioned earlier, will actually cause the enzyme or the valproic acid to increase in level. No, not the valproic acid, but the other medication, okay, which in that case was Lamictal. All right, sedation, remember, is always going to be an issue with these anti-seizure drugs. And then suicidality. I didn't mention that before, but when we talk about having the family inform us of any mood changes with the patients, particularly for those who are on, right, if a patient's on Keppra, we might, with the mood changes that are already happening there, we might also want to ask about suicidality, suicidal thoughts, okay, or behaviors. Okay, even though it's an issue with all the drugs. I mean, just know that all the anti-seizure drugs are just problematic. Okay, they're gonna, pretty much everything that you can do as a nurse, you're gonna be doing. But I want you guys to know the specifics for each drug. Okay, just generally speaking, follow the slides, and I think you'll be okay. Remember too, adherence. You know, never want to stop these abruptly. Try to give at the same time daily if possible, because when those therapeutic drug levels are so tight, giving at the same time daily really helps to keep things in range. Okay. All right. These are other safety indicators, right? We might not want them to bathe alone until we have some stability with the medications. Avoiding heights, wearing an ID bracelet, a medical ID bracelet, can also be helpful too, using technology to keep the patients safe, especially those who live alone or, you know, live in a facility. All right. So I have a transitions of care slide here, and this is pretty much more of what I was talking about in that last slide. And just one more statement around pregnancy. All right. Before the patient is pregnant, we want to, but we're talking about patients who have seizure disorders. We want that patient to have as much intervention or input from their other physicians as possible. Okay, because those patients are essentially going to be put on one drug at the lowest dose. Whereas before they were pregnant, perhaps they're on 2 or 3 anti-seizure meds to manage everything, right? They need to go down to 1 and be at the lowest dose. So this will involve neurology. There's a lot of titration involved to get to the dose that doesn't cause any problems for the pregnant individual. Now, they definitely won't be on the drugs that are teratogenic, okay? So think about that as you're studying. Drugs that are teratogenic should not be given to someone who wants to be pregnant. All right. All right. We're going to prefer Lamotrigine and those and Keppra. We mentioned those before, Lamictal or Keppra. Those are the latest drugs that tend to be more tolerable and are not part of that 3-drug dark triad, right, of the ones that actually cause so many side effects. So those last 2 that we talked about are great for pregnant populations. Okay. Folic acid should be a preconception training for education point for everyone. All right. And then document that counseling, because you just, as a nurse, do not want to be the nurse who didn't provide the right education, and then your patient went on to have something that was preventable, like a baby born with spina bifida, because they just did not have that documentation. And if the hospital were sued, if the doctor's office was sued, and they come back to look and see if the patient received the actual education that they should have, and it wasn't there, that patient is likely to be able to have a good case for remuneration or some kind of resolve because they were not properly counseled. Okay, so it's a big deal. All right, I had just a few graphics for you guys that might just, give you another way to look at some of the do's and don'ts associated with seizures. The stages of a seizure included here. I just got my hands on some graphics and threw those in there. All right. But yeah, that is all for us today, guys. Want more active learning review on today's topic? Stop by the Coach Candace RN Community tab. That's where I post daily practice NCLEX style questions to help you assess what you've learned today. You can also check out my playlists for more nursing lectures on NCLEX review topics and exam strategy. There are pathopharmacology lecture videos on neuro, endocrine, cardiology, and many more NCLEX topics to come.